there's the possibility of changing people in a single session. And over the years, I was in primary care 15 years. The average number of times I saw people was just a little over 2 times. So in focused ACT, as opposed to ACT, we place a premium on precision medicine. It's a term we use in the United States.
Este clip pertenece a la primera clase de una formación internacional histórica en terapias contextuales, ACT con algunos de los referentes más importantes del modelo, Kelly Wilson, Carmen Luciano, Kirk Strosahl, Robin Walser, Francisco Ruiz y Bárbara Gil Luciano. Clase en directo con acceso posterior en diferido, con subtítulos en español y algunas opciones de pago a plazos. Inscríbete ahora en nuestra web www.engranapsicología.es.
So people often ask, what is focused ACT? How is it different than ACT? A little story here. When I met Steve Hayes in 1986, ACT was then unknown anywhere. And we had a little manual. I wasn't his student, but we were working together in a mental health system that I was the research and special projects director for. And we wanted to apply what would later be called ACT in a training program for my therapists. There was about 80 therapists. Back then, it was called comprehensive distancing. That was the name. But at the time, I was working and continued to work in general medicine. So I worked for a while in a brief therapy clinic for maybe 4 or 5 years. And then I was part of a group that went out into general medicine in our system. So I was working side by side with doctors in the exam room area of the medical practices. I wasn't in a room somewhere upstairs. I mean, I was right in the middle of the action. And one thing that became glaringly obvious is we have to get stuff done fast because general medicine moves fast. People don't come in like they do for therapy. They come in maybe once and then they'll come again in a month or 2 months or 3 months. So there's a lot of necessity of learning how to get things done in a single visit. And that's where I used ACT, actually. So a lot of stuff that goes in the ACT books, if you've read them, you'll see a definite sensibility in there that there's the possibility of changing people in a single session. And over the years, I was in primary care 15 years. The average number of times I saw people was just a little over 2 times. So, think about this. The average number of times I was seeing people is you see them once, and then you see them back, and they're done. Now, there's a standard deviation around that. It wasn't like everybody had that pattern. But the average over thousands of patients was you can get single session change, and people come back because you want to see how they're doing, and they're doing fine. They've improved. They're ready to go at it by themselves. So in focused ACT, as opposed to ACT, we place a premium on precision medicine. It's a term we use in the United States. So we want to be very precise. We want to focus the conversation on the things that we know are turning people in a negative direction, and we want to try to turn it in a positive direction. We don't focus on symptom reduction. We focus on functioning. How are you doing with your family, your friends, your work, your play, exercising, substance use, spirituality, not your typical diagnostic interview. We want to acknowledge that the pain the individual is under when they come in to the room is part of life, and we can treat that with compassion. And modeling compassion and an openness and a curiosity is helps people who have the pain do the same thing, which is we're not trying to just instinctively push away from what hurts. We're kind of curious about what hurts and what are we going to do with it. Choosing is basically, if you're not going to live your life according to avoidance rules, then what are you going to live your life about? And that's where values come in, right? If you're going to live your life to avoid stuff, you don't need values because avoidance will tell you what to do in every situation. But if you decide, I'm not going to do that, then what are you going to base your behavior in? And that's going to be what matters to you. What do you seek to be about? And then the key part is take action. So every visit, even the first visit, in fact, ends up with the person committing to trying an experiment that changes the way they're behaving in some situation. The reason it's precision medicine is because we don't just randomly go in and start changing stuff. We start looking for the hot spots in people's lives. Often they don't even know what those hot spots are because they're so busy battling their emotions that they've lost contact with what is actually producing the way you're feeling. So what is producing the way you're feeling is what we would call a hotspot. That might be, my wife and I can't agree about money, and so we just never talk about it. And every time I look at my checkbook or on my online account, I see she spent money that we didn't talk about, and I get angry, and then I don't want to talk to her about other stuff because it might spill over into us talking about money problems again. And that's how, what's the old saying in America? The road to hell is paved with good intentions, right? So I'm trying to kind of avoid this over here, but the avoidance also then generalizes very rapidly to other situations. So let's think about focused act in just a general sense. It's a transdiagnostic approach, so we don't believe that it only works with certain kinds of mental health issues or addictions, or it's basically a integrated approach to assessment, conceptualization, and intervention for many problems. And when I say many problems, I mean we've done, in fact, for psychological, social, medical problems, biological problems, anything that comes into this zone of something you don't want, right? That can happen in the psychological world, it can happen in your social world, it can happen in your medical world, because we are taught to do the same basic thing every time we run into something we don't want, which is to try to get rid of it. We try to focus on a single problem issue using a contextually oriented interview. And I was modeling that a little while ago. So we're not asking a lot about symptoms and severity and all that. It comes up in the conversation, but we're really asking about how are things going at home? How are things going at school or at work? How are your relationships? You know, that's where you find the pain. So why do we do the contextual interview? Because that's where the pain is. When you talk about the reactions that people have to painful things, that's what DSM-5 does, which is let's just start to catalog your reactions, which completely misses the point. It isn't about your reactions. We don't need to get rid of your reactions. We need to get rid of what's causing the reactions in the first place. This is a very skill-based approach. So we believe, this is psychological flexibility is a set of skills, and you can teach people these skills in short, concentrated sessions. It isn't something that you have to spend months at. It's getting people to practice a skill out in the real world. That's a flexibility skill. We're aiming to improve their functioning. We try to take what we call a strengths-based approach. So we're not trying to find psychopathology. We don't actually believe in that term really anyway. It's not a pathology to, not function well. I mean, we all have this problem. We all have times in our lives when we don't function well. So it's not a pathology. It's just something in that particular situation. I didn't have the skills, the flexibility skills to execute. So I wasn't able to be effective. Mostly, we are adapting the treatment to the amount of time and energy that the typical person has for therapy, which is very, very limited. If you look at the data, the average number of sessions that people attend psychotherapy is about 4 to 5. And all of our evidence-based treatments, get this, are 12 to 16 sessions. So they must be seeing people that don't exist anywhere else in the world to get them through these trials, because the average person out there, you're halfway through your protocol, they're gone. And what we know is the minute people start to feel better emotionally, the minute they start to feel reassured, which happens right away in therapy, they tend to drop out of treatment. So about 45 to 50% of people have dropped out by the 4th or 5th session. Dropouts, I don't mean they talked to you and then you agreed they weren't going to come back. They said they were going to come back and they never showed up again. So you're in the middle of whatever you're doing and the person left, you didn't get to do what you were going to do. In fact, the whole model that we're going to use comes out in the first 15 minutes of the first visit.
Si quieres profundizar en lo que has visto, recuerda que puedes acceder a las clases en directo, verlas después en diferido, contando con subtítulos en español, y además elegir entre varias opciones de pago a plazos. Inscríbete ahora en www.engranapsicología.es.